Thank you. It's a real pleasure to be here, and I want to thank people for asking me to speak here. I'm delighted to speak about new diagnostics and diagnostic approaches. First of all, for antimicrobial susceptibility testing, in terms of human health, the end result is to improve patient care. And quite often, the immediacy of that requirement is often lost. In addition to that, we do resistance monitoring, and we've heard a lot today about surveillance, which is retrospective and not prospective. I'm wondering if we can marry diagnostics so that they're actually prospective and at the same time accomplish the retrospective needs of surveillance. So, antimicrobial susceptibility testing has a variety of purposes, including detecting emerging resistance, effective stewardship, and so forth. And the reason we do that is, here's a little example of Neisseria gonorrhea, one of the microorganisms on the WHO priority list, which may become untreatable in the very near future. Detecting antimicrobial resistance, in fact, the methodologies have not changed in decades. They're highly driven by regulatory agencies and interpretations, and none of those agencies has actually been exhaustively discussed today and how they can be impacted to quickly accommodate changing and emerging technologies. The technologies I've shown here are for agar dilution and e-test, which are the recommended methods worldwide for testing the susceptibility of Neisseria gonorrhea. In low and middle income countries, this is virtually impossible. They've lost the infrastructure for any diagnostic testing. They don't have the money. They don't have the way to interpret it. So basically nothing is done. We're also losing capacity, as we saw earlier, in developed countries for organisms like Neisseria gonorrhea because of the diagnosis through nucleic acid amplification testing. And antimicrobial susceptibility testing has simply not kept up with the changes in technology for identification of pathogens. At the same time, the proportion of resistant isolates that's being tested, a very small proportion, is increasing. How to examine this? Well, for example, if we use Neisseria gonorrhea as an example, there are multiple resistance mechanisms to multiple antibiotics. And if one was going to consider advances in diagnostics, we'd like to consider techniques that would actually encompass all the resistance mechanisms at the same time and also give information about emerging resistance and possibly identification of microorganisms and strain types. So it's not enough just to have little pockets of diagnosis, but we want a more integrated diagnosis that can be used and played forward. There are many PCR diagnostics for antimicrobial resistance. Very few have been commercialized. Very few have been accredited with the international agencies. They're largely research-based by national microbiology laboratories. I've given again an example of Neisseria gonorrhea, where for each gene, basically single nucleotide polymorphisms associated with antibiotic resistance are identified after a fairly tedious PCR analysis followed by DNA sequencing and subsequent bioinformatic analysis. Nevertheless, there's been high sensitivity and specificity for this kind of assay, and in particular, ciprofloxacin, not only for Neisseria gonorrhea, but for other microorganisms. Mutations in GyRA, for example, the gene encoding resistance, are very, very predictive of ciprofloxacin resistance. So this has been chosen by several commercial organizations to commercialize as a test. However, in order to get this whole spectrum that we need for diagnostics, we actually need some disruptive technologies. And whole genome sequencing promises to be one of those disruptive technologies. Right now, it's very much research-oriented. The databases that people are acquiring are not in the public domain, and there are limitations with respect to cost and expertise. However, this should rapidly change in the future. The other aspect about whole genome sequencing is, again, a very nice study in which Canadians participated, where one was able to predict susceptibility rather well to a variety of antibiotics based on the analysis of the whole genome sequence for various antibiotic resistance determinants. Of course, this doesn't predict emerging resistance, but the fact is, with whole genomes, once we have a problem, something can be retrospectively analyzed. Often forgotten is the development of bioinformatic pipelines for clinical WGS applications. Yes, we have bioinformatic pipelines for research-oriented analysis of isolates for which, we do whole genome sequencing. Again, is it in the public domain? Is it in the clinical domain? Can it be used in the clinical domain to actually give a profile of antimicrobial resistance of use to several users, clinicians, lab heads, epidemiologists, and so forth? If we had this information, which is entirely possible, epidemiologists could then go and track basically patient information without some of the tedious methods that are currently ongoing. And outbreak prediction would be prospective and not retrospective, which is a huge problem with AMR detection. There are many applications of molecular testing, and point of care is definitely one. The WHO stresses a technology-oriented definition of point of care, little pregnancy-like tests. But of course, there's an alternative definition, and Nikita Paiv from McGill University is a very good proponent of this, where point of care is diagnostic testing that will result in a clear and accountable management decision. That implies that point of care testing might vary in very sophisticated tertiary laboratories as opposed to a rural laboratory with no facilities. But it will accomplish the same thing. Low numbers of isolates will be rapidly evaluated for antimicrobial susceptibility, and there will be mechanisms for data mining and preservation. In fact, point-of-care tests have been used to introduce ciprofloxacin therapy for gonococcal infections, and that effectively reduced the amount of ceftriaxone, one of the last antibiotic bullets for the gonococcus. In addition, a province like Saskatchewan has over 95% of its isolates susceptible to penicillin, but Canadian treatment guidelines specify other more expensive drugs. A point-of-care test would enable an antibiotic like penicillin or ciprofloxacin to be tailored to individual patients. So the future for whole genome sequencing are portable devices, even in the field for veterinary medicine and many other things. And in fact, while these are still in development, they will be used in the future. And recent publications have indicated that you can use WGS for antimicrobial resistance determination and do it within a very short period of time. Imagine if we identified multiple pathogens at the same time from clinical specimens. There are a variety of other diagnostic approaches for AMR under development. Microfluidic applications, which I'm going to talk about, leveraging ultrasensitive detection methods to relay phenotypic information, mechanical transducers such as atomic force microscopy, electrochemical sensors, electrochemical bacterial phenotyping, MALDI-TOF, fish fluorescence in situ hybridization, and so forth. Microfluidics is where one manipulates and controls fluids in very, very small amounts in networks of channels with dimensions from tens to hundreds of micrometers. In other words, it miniaturizes microbiological assays, allows one to assay very, very tiny concentrations of microorganisms in short periods of time. In this particular example, a blood sample is being separated from bacteria, blood cells from bacteria, and then once that is done, other platforms are used to identify the bacteria and antimicrobial resistance. And this is the kind of point-of-care test that might be used in a sophisticated tertiary facility. Other rapid AMR testing methods include single-cell methods, which again include microfluidic agarose channels, in other words, single cells on a chip, and you flow through antibiotics and then look for growth characteristics under a microscope. All of this can be electronified and documented. There are several microfluidic strategies which depend on growth. For example, this microfluidic chip looks at the growth of individual cells from the poles and records it, and when they're exposed to antibiotics, it records that and compares it to an enormous database. My question is, where's big data in this? We're all individualized. Why not introduce big data to develop some of these methodologies? Some of these methodologies have been commercialized, where in fact they use fish to identify microorganisms through microfluidic sort of channeling, and then the microorganisms are subsequently monitored for growth of individual cells or colonies, and the differences in growth are evaluated microscopically. All of this is automated. So final thoughts. There are many innovations for the rapid and accurate diagnosis of antimicrobial susceptibility. Commercialized strategies with other innovations are being actively developed, but are our regulatory agencies nimble enough to actually respond to these innovations, and are we nimble enough to utilize these formulations? And in fact, molecular and WGS, whole genome sequencing, might actually be a better alternative in low and middle income countries than many of the costly microbiology-based, phenotypically based methods that are recommended. Thank you.